Hi everyone, my name is Rakib. I'd first like to thank Mr. Richard and Mrs. Pia for having me out here. I work with Dr. James Bernick, who was actually a presenter here the past couple of years. Unfortunately, he couldn't make it today, and he sends his regards. So I'm here in his place and having a chance to kind of go over our current research. So for the past 2 years, I've worked with Dr. Bernick on Gulf War illness. Many of you might have heard of it, many of you might have not, but similar in terms of the symptom presentations with ME and CFS. Now I'm going to go over a brief history of what just Gulf War illness is. During the 1990 and 1991 first Gulf War, it was considered to be one of the most successful wars because it happened in 7 days and troops were finished with everything, and it was considered to be a great success. Unfortunately, even before the war ended, a lot of the troops started complaining about having symptoms of cognitive fatigue, physical fatigue, IBS, etc., etc. Now, if we fast-track into the 20 years from then to now, what we see is that over 30% of the 700,000 veterans who've served in the Gulf War in the United States have this symptom complex, which we now know as Gulf War illness. It's also been seen in the other Allied force soldiers in the UK, Canada, and Australia. Excess prevalence of symptoms have included fatigue in veterans from the US, UK, Australia, Denmark. We've also seen headache, memory problems, muscle joint pain, diarrhea, dyspepsia, neurological problems, in fact, even tumors. Again, this is the quick summary here. Happened in 7 days, and unfortunately, even after the war, and there's been considerable research on Gulf War illness, the DoD and the VA in the States haven't been that great in terms of accepting that this has been an ongoing illness and a debilitating one at that. In fact, the VA has no diagnostic code, so many veterans who do go to the VA and see their clinicians are met with skepticism and pretty much just do not get any treatment. A lot of veterans that I have had the opportunity to meet are still fighting for their benefits today. It's been 10, 15 years that they have been going through this situation. Now, there are a lot of potential causes that could be underlying this type of illness. Many have said that the oil well fires, the smoke, combustion, fine particulate material, vaccinations could have underlied these differences or changes that we see in terms of the symptom complexes. Unfortunately, I think since 20 years has passed, it may be difficult to know what that exact causal relationship is or what that molecule or metabolite that may have caused these type of changes. But hopefully today I'll be able to at least shed light on the pathophysiological mechanisms that may underlie some of the symptoms that we do see currently. One of the big theories with Gulf War illness is that the munitions dump blow up in Kamasia was considered to be a causal, quote-unquote, situation that could have caused these symptoms. In summary, it just was the blow-up of multiple munitions dump held by Saddam, and the exposures and release from these munitions dumps included sarin gas, other agents, and so that type of fine particulate things in the air may have caused the changes that we see in our veterans today. Sarin is a potent acetylcholinesterase inhibitor, and sarin and other nerve agents bind irreversibly to acetylcholinesterase, and this is something that has been talked about also in ME/CFS, this type of acetylcholinesterase issue. This mechanism is shared with commonly used insecticides such as malathion, carbamates such as 7, and the drugs persistacine, neostigmine, and phytostigmine. Again, possible causes. One of the biggest ones that have been pushed by the VA or the government is PTSD and the effects of that traumatic stress from the Gulf War itself. Now, Dr. Steele, who works at Baylor University in Texas, has done a wonderful study on looking at the complex factors in the etiology of Gulf War illness. And her recent study that came out in last year of 2012 in January, she saw that there was no significant odds ratio for common things that we know may have caused PTSD often in soldiers. And if you look at the lower end of the screen, we see that contact with prisoners of war, seeing badly wounded or injured troops or dead animals have no significant odd ratios whatsoever with Gulf War illness. And so the idea that PTSD may be the underlying cause of Gulf War illness seems to not hold up here. However, what we see is that there are significant multivariable associations with deployment, one of them being Scud missile explosion within 1 mile, uniforms that were treated with pesticides during that time, also less than 4 hours of sleep, and taking the PB pills. Now, all these combined may in fact have caused a probably lethal cocktail in terms of the symptoms and symptom complex that we do see as known as GWI, Gulf War illness. And the final impression that we may be able to take from all this is that ACH or acetylcholinesterase esterase inhibition with acute and long-term ACH toxicity. Now, this kind of goes into the current work that we've been doing. In summary, Dr. Bernick has hypothesized that because the similarity in symptoms with GWI and ME/CFS are there, that may, in fact, if we exercise the veterans and pretty much put them into a scanner before and after exercise, we'll be able to see some differences in their brain. And the fact that central nervous dysfunction or central nervous system dysfunction may in fact cause all the symptoms that we do see. One of the things that I think Dr. Peterson touched on earlier, and even something that I saw the past couple of years, is that there are multiple criteria that are used to identify whether someone has GWI or CMI. There's the Kansas definition, there's the one by Fukuda made in 1996. There's also multiple definitions in fibromyalgia, chronic fatigue syndrome, ME. And what we see is that if we just look at them all together, we're able to kind of make a potential consensus criteria. And that's something that, again, as Dr. Peterson has said, we might need to start, or we should start moving towards more objective outcomes. And that's pretty much the summary of what I'm trying to go over today. So the model system that we use to study the symptom alterations is we put everyone on a bike, exercise them, VO2 max, twice. And before the exercise test, we put them into an fMRI. It's just a big scanner, and we look at their brain. And we have like a baseline of what their brain looks like before exercise. 2 consecutive exercise stress tests, and then we put them into the scanner again. Look at post-exercise changes that happen in the brain, whether it be blood flow changes, structural changes, but the hope was that by doing this type of protocol, that we'd be able to see what the brain is doing when it comes to the symptom known as post-exertional malaise, which a lot of veterans have complained about, and a lot of ME/CFS patients have also said that it's been a prominent, if not cardinal, complaint of their disease state. So the first thing that I'm going to go over is the static differences at baseline that we saw on the fMRI when it comes to the Gulf War veterans versus a control group. But before I do, I want to go over the technology. Oftentimes, neuroimaging technology has a lot of acronyms in it, and the first one that we're going to go over is DTI, which stands for diffusion tensor imaging. Now, this type of technology, what it does, it looks at the orientation of protons in the water molecules in a magnetic field. So when you stick someone into an fMRI, which is a big magnetic field, the water molecules and the axons of the brain orient in a different direction. So the axons that are wrapped with myelin, the axons have a linear, more axonal parallel arrangement when it comes with the water, and the myelin has a more of a radial arrangement of the water molecules when it comes to being put in this magnetic field. Now, this is a quick little picture of it, but if you took maybe, let's say, a glass of water and you poured it on your desk, what you see with the water is it diffuses everywhere, moves randomly. But water is something that is very malleable, I guess you can say, and if you put it into a glass, you see that the water itself fits the glass, and it doesn't, it will fit whatever it goes into. And that's the same situation that we see here, is that because of the way the axon is in the white matter, or the myelin that wraps the axon, water is restricted in a way that allows you to kind of figure out the integrity of that white matter. So AD stands for axial diffusivity, and it looks at the integrity of the axon, whereas RD stands for radial diffusivity, and it looks at the integrity of the myelin that wraps around the axon. If you take those numbers and you sum them and get an average, you get something called a fractional anisotropy or mean diffusivity. In general, what we do is we take all the white matter tracks from this voxels and we average them and we look to see what these AD and RD vectors are doing. Normals or controls should have a significant or a unique look of what these values should be, and our hypothesis was that Gulf War veterans may in fact have differences in the white matter integrity in their brain. So this is a recent study that got published in March 20th in PLOS One that looked at the white matter integrity in Gulf War veterans. Prior to the meat of the experiment, one of the things that I was able to notice, and I'm sure a lot of researchers and clinicians have noticed, is that even if there are subgroups or subsets, two of the main complaints has always been pain and fatigue. And in fact, with a lot of the veterans that I had a chance to meet, many of their complaints when it comes to pain and fatigue and the severity of it would often move and shift in parallel. So if someone had higher pain, they would have higher complaints of fatigue. And this is just a correlation of the subjective variables. What we used was a dolorimetry, which is just pretty much pushing a pressurized gauge on someone's 18 tender points. We also used an ordinal fatigue scale from 0 to 4, and we used the McGill pain scale, which is just a questionnaire going over several types of feelings of pain. And what we see is just something very simple, again, is that the correlation between their systemic hyperalgesia or their dolorimetry scores, which is the difference when it goes from pressure to pain, and we tell the patients to say ouch at that point, and their McGill total scores correlated. Same thing with their fatigue scores and their McGill total scores, and their ordinal and dolorimetry scores again. Now, in this graph, the yellow circles or yellow bar graphs are controls, and the red bar graph and the red triangles are our GWI subjects. The last column shows us ROC curves that, again, because they're on two ends of the spectrum, you can separate Gulf War veterans from controls when it comes to these three subjective correlations. One of the most important things that we try to answer in our research study is what are the objective underlying mechanisms that go with these type of complaints. And I think that's, again, one of the hopes of researchers try to answer that. So now what we saw was that when we took all the DTI and the white matter evaluations, we saw that the ordinal fatigue, the dolorimetry, and the McGill total score, in fact, correlated very well with the right IFOF, or the integrity of the right IFOF when it comes to the axial diffusivity. Overall, I think if you look at column B right there with the bar graph, what we see is that Gulf War veterans have increased axial diffusivity in the right IFOF, and the IFOF stands for the inferior frontal occipital fasciculus. Now, again, the next step was, does this increased AD correlate, in fact, with subjective variables that we see, or that we were able to measure? Indeed, it does. With the ordinal fatigue, dolorimetry, and McGill total scores, we saw a very significant correlation. All of the p-values are under, I would say, 8 times 10 to the negative 3 when it comes to the correlations. But what was really important was the values of the right IFOF, or this increased AD in the axon, could separate the groups. In summary, what we saw was that the values of the axial diffusivity in the right IFOF was, in fact, you could separate the two groups, and you see the ROC curve on the right bottom hand of the screen. The AUC, or the area under the curve, was almost 82%, so it was quite a robust biomarker here for being able to separate the two groups. This study was really great in terms of understanding that there is some type of central nervous system dysfunction here. One of the limitations of this study is that because we're using DTI, diffusion tensor imaging, What is the exact molecular changes that are going on? No one knows. I think the gold standard obviously would be a histological examination to see what this increase in axial diffusivity in fact means. Again, the red triangles are our Gulf War veterans. The yellow circles are our controls. The right IFOF connects two regions of the brain that are implicated in fatigue and pain processing. The right IFOF kind of goes from your prefrontal region and goes back towards your occipital region, connecting your anterior insula. One of the biggest things about the anterior insula, it has been implicated in the processing of your pain perception. And the prefrontal has been known to be involved in processing your fatigue as well. So this was quite I would say, an exciting finding for us. Now, this was one of the ancillary findings of the study. We also saw that there was increased AD in the left corticospinal tract and increased MD, which is mean diffusivity, in the superior longitudinal fasciculus in veterans. The superior longitudinal fasciculus controls cognitive memory, has also been implicated in working memory as well. And the left corticospinal tract is a common tract known in just normal, I guess, hand movements and motion. So we have also seen that the AD in the left corticospinal tract, in fact, was also able to show potential as a biomarker, being able to separate Gulf War veterans and controls. And we saw, I guess, similar things in the left IFOF, the left inferior frontal fasciculus, and the right and left uncinate, which are white matter tracts that connect emotional regions in the brain. Now, after that was a baseline change, and this is kind of the meat of the study here, which is the dynamic differences that we saw due to a physiological stressor. We looked at cognition before and after exercise, and we used the two-back working memory task. I don't want to go too much into it. It's long story short, you look at a letter and you have to remember what happens to that letter to before, and you have to press the button while you're in the scanner. So we did this cognitive exam while they were in the scanner. We also looked at metabolite changes due to exercise. We looked at cerebral, lactate, glutamate, and glutamine. Glutamate is the most common neurotransmitter in the brain. Cerebral lactate possibly shows some type of dysfunction in the mitochondria or the white matter in the tracts. The second thing that we looked at were clinical outcomes, which were cardiovascular indices, such as absolute supine and orthostatic changes in heart rate and blood pressure. We also looked at pain pre and post exercise, systemic hyperalgesia, and also thumb pressure at the 18 positive tender points, or 18 tender points. So this second study was also recently published, and it looked at the metabolite differences before and after exercise in Gulf War veterans. And what we found was that two subgroups appeared before and after exercise. What we see here is that the two-back working memory score for the blue group, which we've labeled as increasers, in summary, and after exercise they had an increase in their working memory score. But what we saw was another subgroup of Gulf War veterans after exercise had a decrease in their working memory score. The slide or the picture on your left shows the Voxel placement, where we placed a spectroscopy Voxel in the left anterior cingulate cortex to see changes in the metabolites. Now, in this two-back working memory exercise where we looked at the differences in the lactate values and any other metabolite values, what we saw was that our controls were very high up on the scale of accuracy, whereas our Gulf War veterans had this very different change where some were increasers and some were decreasers when it came to their scores. And this was just the accuracy values on the two-back working memory. For a while, we had a difficult time of trying to figure out why did we have a subgroup called increasers, or had an increase in their score, why did we have a subgroup have a decrease in their scores? And what we later found was that the increasers pre-exercise had lower values of lactate than the decreasers pre-exercise, as you can see at the x-axis on the A, day one. The decreasers, which are in green, had much higher cerebral lactate levels. Now, recently, cerebral lactate levels or increased levels of it have been shown to be associated with mitochondrial dysfunction in aging, and also in MS. And what we saw was that after exercise, we had a proportion, the increasers have an increase in their scores, an increase in lactate levels. Now, this increase in lactate levels, recently the brain has been known to use, in fact, glucose, but in this case, we've seen that the brain may have utilized lactate as an alternative sugar source. And we also looked at, in this study, the changes in glutamate and glutamine ratio. We saw that the increasers had an increase in that ratio, which probably meant that the neurons were functioning much better in that region. And this was one study that got recently published. Now, I would consider this the piece de resistance of our work in terms of understanding what may underlie the physical changes we see in Gulf War illness. So a part of, and this is a complete separate study that should be out in the next couple weeks, but a part of the complaints that when I first started working there was a lot of the veterans would say, I have heart palpitations and I don't know, I feel lightheaded at times or dizzy, but when I go to the doctors, I complain about this, but I don't show that symptom at the doctor's office, and it kind of stinks because then the doctor doesn't believe me and I'm starting all over again with said doctor or clinician. But what they also said was, when I do a stressful type of exercise or some type of moving or maybe a cognitive exam, something that's stressing me out, I see that there's these marked differences. So that was one of this type of clinical finding was one of the reasons why we thought that maybe exercising the veterans and seeing what happens pre and post exercise may in fact show us these differences in the brain. So if we look before exercise, what we see is that well, the thing is that the red triangles are a subgroup of veterans that had increase in tachycardia or orthostatic tachycardia after doing an exercise. But before exercise, what we see is that you can't tell the difference between controls, which are the cyan circles, the yellow squares, which I'll go over in the next slide, and the red triangles, which are our tachycardia group. So, in summary, after the first exercise, we had 10 participants with Gulf War illness develop orthostatic tachycardia, and they had an increase in heart rate above 30 beats per minute twice on their blood pressure cuff. And they had this consistently throughout the whole entire protocol, the first and the second exercise, and it kind of went away, or it actually did go completely away after they had a full night's of rest. So we've termed them the stress test associated reversible tachycardia phenotype, or the START phenotype for short. And the next group, though, which is on the next slide, the yellow squares, what we saw was that although they didn't have an increase in tachycardia, what they had was an increase in their perception of pain significantly. As time went on throughout the protocol over the 4 days, they had more complaints and significant more tender points throughout at the end of the day after the 2 exercises. Because of that, we call them the STOP group, or stress test originated phantom perception phenotype, and they're the yellow squares here. Now, these 2 clinical complaints, orthostatic tachycardia, or increase in heart rate, increase in the perception of pain after a physiological stressor, is something that has been reported consistently in CFS and ME, in fact also been reported in Gulf War illness as well prior. However, it's been difficult to kind of pin down why we see these type of symptoms that we do. So on this next one, what we see is that we looked at their brain blood flow when it comes to their cognitive task of the 2-back working memory. And before exercise, what we see is that controls show normal blood flow in working memory regions. And again, they look like controls. But in comparison, our 2 subgroups now, the STOP and the START, show compensatory activity in different regions. So the STOP group, and this is because it's a macro view, but the STOP group showed increased activity in the basal ganglia, or increased compensatory activity. Whereas the START group, if you look at the right-hand cerebellar picture, they have increased compensatory activity there during the 2-back working memory task, something that is quite different and quite contrasting when it comes to looking at the controls. This is important because a lot of the veterans, again, have said they've taken neuropsych tests left and right with their GP or with their clinician, and the clinician always says, you're not significantly different from normals in terms of these neuropsych exams. This might be explained by the fact that we see compensatory activity here, meaning that the brain has somehow found other scenic routes to kind of take over for damaged areas of the brain. This type of compensatory activity in the cerebellum in the start group and increased compensatory activity in the stop group is akin to what people see in Alzheimer's and multiple sclerosis. So these type of neurodegenerative diseases, you see this type of increased functional compensatory activity. Now, after the exercise, what we saw was the start group, which had the increased tachycardia, had complete loss of blood flow to all regions of the brain, almost like a hypoperfusion. The stop group, again, as you can see, had a similar type of hypoperfusion, but less than the start group. In fact, they had increased blood flow in other regions that showed that they were trying to compensate for the fact that they were quite exhausted. Our controls showed pretty much normal blood flow functioning after exercise. In fact, they showed automaticity, which is just the fact of being able to learn and becoming more efficient at the task. Now, one of the biggest limitations of many of the studies has been that they've always been on a spectrum. So on a working memory task, you have an accuracy. And on that accuracy, you have a spectrum. You have some people who do really well, some people who do in the middle, some people who do really great, which are our controls. That has always been a question that a lot of researchers have asked me is, well, if someone's on a spectrum, is that just normal? Are they just on the normal part of the spectrum and just tends to be that they're on the far end of it and that's why they're considered to be sick? And so one of the most important things is that we were trying to look for things that separated groups completely. And our start group, which is the group with the orthostatic tachycardia, if you look at the middle pictures, what we see is that the start group comparison to controls had cerebellar atrophy, pons atrophy and medulla atrophy in regions that are in the general brainstem. The brainstem, as we all know, controls all of your cardiovascular indices or your blood pressure and your heart rate. So the fact that we found this in our subjects who had this increase in heart rate was stunning to us, very exciting. Our stop group, which had the increase in the pain feelings, had, if you look at the right-hand photo, the right superior gyri, they had decreased brain matter in the right superior gyri, which controls your pain perception. So they had that loss of atrophy, which may in fact mean why they have this type of increase in pain perception. The left lingual gyri, cerebellar tonsil, and right cerebellar culmine are also in the start group. We see this atrophy in these regions that may in fact control cognition in the left lingual and the cerebellar tonsil, which is also known to control cognition and common motor movement. So in summary, what we saw was when you do subgrouping based upon this objective stressor, you're able to see differences in their brain matter, which may in fact underlie why we see the symptoms that we do. So summary and future implications here is that possibly ACH or acetylcholinergic, I always have a hard time saying it, acetylcholinergic exposure and toxicity may have led to damage in the central nervous system. Exercise can be used as a potential model to study overlapping symptoms such as ME and CFS. And subjective criteria that I showed prior can possibly condense and supplement it with objective outcomes, hopefully things that are neuroimaging in nature or clinical indices. And that's it.
Thank you very, very much indeed. Well, we have about 10-15 minutes for your questions before we have a break. So would someone like to start off asking any one of the speakers?
Brostoff, King's College London. Very interesting talk. I just wonder how often you think of comorbidities. If you take the postural tachycardia syndrome, POTS, postural orthostatic tachycardia syndrome, that is associated with joint hypermobility, Ehlers-Danlos type 3. It's present possibly in 20 to 30% of the population. That is going to skew your data hugely because it's the comorbidity rather than the CFSME that's doing the problem. Of course, there's a major connective tissue abnormality over the whole body. Secondly, the myalgia and pain has now been shown to be associated with alterations in magnesium flux. So if you do mitochondrial function, some of the severely myalgic patients have very low magnesium levels, and the pain and regeneration can be altered by magnesium supplementation. But sometimes there's slow ADP to ATP, so there's going to be an increase in lactate purely due to magnesium transport. I'm always concerned that some of the early literature on this has not been read, and because it's my paper, I suppose I have a special interest.
Of course.
But we showed many years ago that with using a SPET scan, the actual blood flow to the basal brain and the cortex is significantly different in depressed patients and patients with CFS. CFS patients have a significant deficiency in blood flow, statistically measured, and depressed patients have an abnormality in cortical blood flow. Now, that's a functional difference in blood flow, which must make a difference to the management of energy balance in the body.
There you go. Another interpretation of your data. What do you say?
I think in terms of the discussion of the changes in magnesium, again, we didn't study those specifics, so I'm just not sure as to maybe what the underlying changes will be. I would say that one of, again, the limitations of our design is that we've looked at the macro in terms of just blood flow changes and the changes in the atrophy and gray matter, but discussion has been now in terms of the micro, which is the changes in magnesium. We just haven't looked at it yet. So it could be a possible underlying cause of what I do see, yeah.
Were you saying in your question that some of the older data, if you looked at it, might give the game away and show you what really causes some of the things, that we're getting caught up perhaps in being too high-tech and too clever by half? Is that what you're implying?
Yes, and the simple things which are comorbidities. For example, the American Academy of Endocrinology has now changed the diagnosis of myxedema. Previously, a TSH above 4.5 was considered abnormal, and now they've reduced that level to 2.2. So you have a very early functional diagnosis of myxedema, that is low thyroid function, based on what is essentially a normal TSH judged by some people, but the American endocrinologists think that's much too high. And that slightly raised TSH can be a significant marker in spite of the fact that the free T3 and free T4 are within the reference range, although in the lower quartile.
Okay. Possibly.
Could be. I guess we haven't really looked at T3, T4, or iodine levels or thyroid function specifically in any of the patients currently in this study. It is quite high-tech, but I think in terms of trying to understand something that clinicians have seen, something that patients have complained about, and something that even my prior two presenters before me have said is that, trying to move forward, we may need to embrace technology a little bit more. And so the hope is that by showing this data in Gulf War illness, that maybe applying the same type of protocol in ME/CFS, we may be able to understand the neurological dysfunction that a lot of the patients do complain about.
I'm sure you guys over coffee can have a little quiet discussion by the data. Just no fisticuffs, please. Okay, I have a question, Dan, for you. This is not absolutely relevant to what you were talking about, but in general it is. It is from somebody who I think has phoned in. Could you please offer advice on treatment of dizziness and vertigo in a totally bedbound 29-year-old female patient? She's been sick for 6.5 years with pain, sleep, digestive, cognitive symptoms, is unable to sit, and is intolerant of most medication, even in small quantities. She has been diagnosed with severe ME. I mean, that's kind of off what you were talking about, but these are the kind of questions that this conference tries to answer.
I think the whole issue of the...
You want to stand up, Dan?
The issue of the severely affected, we've actually had complete all-day meetings with respect to that subgroup of patient that I think all of the clinicians here, we find a great deal of difficulty managing those people, not just the logistics, it's their entire deteriorated physiological selves. There's no simple answer to that, but I think it's an overlooked group of people because they largely cannot access care. In the old days, we would hospitalize those people and give them the hyperalimentation and a variety of things that just aren't economically possible. So I don't have a quick answer to that.
No.
But whoever asked that question, I'd be happy to.
Well, if the person's in the audience, please grab Dan by the ear and you can get more information. Thank you, Dan. I should have warned you about that, but thank you very much. Anyone else? Yes, Charles. Yes.
Charles Shepherd. This is to Rakib again. First of all, I'm very pleased to see you're doing this study into post-exertional malaise, post-exertion malaise. I'll speak to you about it over lunch, but we're actually involved in a European study looking at this, but looking at measuring HPA function and immunological dysfunction, doing similar sort of parameters during exercise tests. But I wasn't quite sure from what you said how far you were with the MECFS group as opposed to your Gulf War. Most of your results were
in Gulf
War syndrome.
Right.
So have you got similar results
No,
from
we
your
haven't.
CFS patients?
We haven't started this similar type of protocol in any ME/CFS patients yet. I think a lot of researchers can share the fact that it's been a difficult funding environment, to say the least. But I think we're excited about the next round in terms of getting the application started up and hopefully getting MECFS. Yes, oh, absolutely. Yes, to try to get an understanding of whether or not we do see these type of changes in MECFS as well. So the hope is in the next, hopefully, year or so, we'll get that opportunity.
Thank you. We have another question.
I think splendidly done. It was a marvellous paper, I think. But I think the warning from Professor Brostock to be heeded. There's a lot of earlier work that needs to be looked at. Could I just ask whether your Gulf War veterans were deployed or non-deployed, or were they not separated in that way?
So we did look at that point. All of our veterans, except for 2, were non-deployed in the study. And we didn't bias in terms of deployed or undeployed. There was just specific criteria. If you met the criteria for CMI and weren't a current veteran or a current military personnel, then you were applied into the study or added into the study.
Well, you need to look, I think, very carefully at the latest work from Haley's group and Tewitt's particularly, who's shown the deployed people were exposed to the sarin and the acetylcholinesterase inhibitors, but the non-deployed usually were not, but they did have vaccines.
Right.
And there's evidence from a British study that the vaccine-damaged people have got severe pituitary damage, so the pituitary is not sending out the hormones that it usually does. So particular loss of growth hormone and gonadotropins were noteworthy. So there is a difference between the 2 groups, so I think you need to be a little bit more careful in how you select your groups, because you could get everything mixed up because you've got 2 groups that have got different insults.
Yeah, I think overall in the study we've realized that it was a pilot study. It was actually very difficult to recruit because it took 4 days of someone's time, and so a lot of people didn't want to get involved because of that. But overall, I think hopefully the results are promising, and we're able to hopefully kind of extrapolate this for CFS as well.
We'll take your question first, then the one in the back. Yeah. Pia, just on the left, that's it. Thank you.
Thank you. I'd like to pick up what the previous question said about pituitary damage.
You stick the mic up.
Thank you. I came here today not because I have any connection with ME, but because our son committed suicide 4 years ago, and we discovered after his death that brain injury damages the pituitary gland in around 1/3 of cases. Now, this is a relatively simple condition. The gland is damaged; it can't make the hormones. You replace the hormones, the patient feels better. A recent BBC Inside Health programme pointed out that there are between 500,000 and 1 million people undiagnosed with this condition in the UK today. This is a very huge number. It's 4 times the people who died in the tsunami recently, in 2004. Now, where are all these people? Where are those 1 million people? And I would guess that quite a lot of them might be in this lecture theatre today. People are being told incorrectly that they have chronic fatigue syndrome when they, in fact, have hypopituitarism. My question really is, why are those who are diagnosed with ME not tested for hypopituitarism? Because that way, maybe a third of these people here today might be, whose lives are being slowly destroyed, might be saved by diagnosis and correct treatment.
Okay.
So, thank you very much.
Thank you very much. Who would like to take that? Is anybody courageous enough to take that question? Yes, sir.
I have a particular interest in chronic fatigue syndrome, and some of you people here will probably know that. But one of the primary concerns whenever I see a new patient with ME, chronic fatigue syndrome, is to make sure that there is no alternative cause for their symptoms. And we all know that in ME patients, the pituitary actually doesn't function properly, and there's a sort of it's as if the volume of hormonal messages from the pituitary has been turned down for reasons which we don't understand. But there are actually plenty of other causes of pituitary dysfunction which are nothing to do with ME or chronic fatigue syndrome. And it's important, obviously, to try and exclude those people when you see them in the clinical context.
Could you give her the microphone? Sorry, Pierre. Yeah, please.
I mean, just a quick question. Why do you think that they are not being excluded at the moment? I mean, about the number of people diagnosed with hypopituitarism is around 2,000 a year.
Okay.
This is very, very far from being the numbers that the Inside Health programme quoted.
I think that the simple answer to that is that the diagnosis of pituitary disorder, which is separate from ME, chronic fatigue syndrome, is quite an involved process and involves, in some situations, imaging the pituitary gland and also doing dynamic tests of the pituitary as well. And that is potentially time-consuming. And I'm sure that endocrinologists across the country, good endocrinologists, won't miss this condition, but won't miss pituitary dysfunction due to an alternative cause. One of the classic alternative causes of pituitary dysfunction that I've every now and again seen is the condition of pituitary apoplexy, where women who've had a difficult delivery and lost lots of blood, their pituitary literally collapses in on itself and doesn't work properly. And in its most florid form, that's easy enough to pick up. But sometimes the pituitary can only be partially damaged, and it's, the ultimate access to getting the diagnosis right is to take a good history and to make sure that you see that you ask all the right questions. And here again, another dimension to the situation affects the overall management of the patient, and that is that many ME patients and many patients with pituitary dysfunction have cognitive difficulties, memory difficulties, and they don't have the sort of detailed information about their subjective sensations which you want to get out of them, and that's where the skill of taking a good history comes in. So you put your finger on a point which is an important one, and that is that part of the whole management of patients with ME, chronic fatigue syndrome, involves taking good history and excluding those conditions which cause the same symptoms, or roughly the same symptoms, and which are much more treatable.
Okay, thank you very much indeed. Cheers.
I'd like to just go back to the earlier paper and just ask a question about the categories of self-reporting and getting this very large sample. I wonder if there's a category which could be, from a research point of view, extremely valuable, but which wasn't in those categories that you could assign yourself to, and that is people who have had diagnosed ME with its full symptoms, who are fully recovered. They could be a seriously interesting group, subgroup. And I'd just like to add that while watching it, I realised that when I had active ME, I actually had tachycardia, which was clinically diagnosed with a Holter, and I've never had the slightest heart symptom of any kind. Nobody's ever discovered it since I recovered. These recovery stories could be, from a research point of view, valuable, and it'd be nice if we could register that.
Thank you very much. And there's one down the front here, yes? We'll make this the last one before we have a little natural break.
I'm not a medical person, but I've done a great deal of research in ME and plan to continue. I do know that in the NICE guidelines, there are definite tests which doctors are allowed to make if they suspect a person of ME, and there's also a list of tests that they're not allowed to make. And I wonder if the list of things that they're not allowed to make, on the theory that you don't want to encourage them to think that they've got a physical illness, would actually limit the doctor's ability to do the testing that would cause the, that would identify the endocrine thing that you're talking about. And there's a couple of nods there. The other thing I wanted to say is I think that I'm very interested in, I think the suggestion about studying people who have recovered from ME is important. I have an absolute bee in my bonnet about rest, which was prescribed by Aitchison and Ramsey very early on. Rest is now a dirty word. Apparently, according to the King's College Information for Physicians, rest is what causes all the symptoms of CFS. It's a very interesting read. But I think that it would be really worthwhile to invite people who have recovered to find out what they did. So
yes.
Please, that I'm just...
Andres will come in on that. Andres, please.
So I appreciate both of those comments, because I think that's exactly the kind of thing we do want to start capturing, and I didn't have time to get into it, but really that's the low-hanging fruit, is not only people like yourselves who've potentially recovered, but also people who are on different medications and are in the process of recovering. We want to be able to measure those, both from a diary, if you want to look at that type standpoint, what were my symptoms then, what are they today, what are they next week, and so forth, but then also hopefully from a biological. But the outcomes piece of this is critical, and it's wonderful to have your stories from a medical perspective as much as you can give, that Holter, before and after and so forth. So please, use the registry to do that sort of thing, and that's why we have those categories on there for... We have healthy controls. We don't have the previously ill one, but actually in the healthy control one, you can put in your medical history, and you can put, thankfully for you, you can put that in your past medical history section, and we'll note that and look at you appropriately. So we'd love your participation on that.
I just say there was a big discussion about that at the meeting yesterday too, of people that you describe, and how you got to talk to them about what full recovery meant, or if there was a thing called full recovery even. There was a lot of unknown, areas that hadn't really been researched. So you put your finger on a very important point, yes. Shall we, sorry, last one then. Okay, I don't want to stop any discussion, please.
About the question of worldwide accepted criteria, but what about the Canadian criteria or the international criteria? And why is it so hard for physicians to coordinate the different specialties for a patient? Why do we have to do that?
Yes.
Why can't they do that? It's so hard for us.
Come on, Dan, we want an answer to that. Dan will answer or try to answer it. That's a serious point, I understand.
It's a very serious question. And I think at the heart of it is we don't really agree as to what the disease is the reason we physicians aren't more proactive. The second point is the CivSec committee that just met last week voted to put off for 2 more years the consideration of clinical and research definition. So I just think we're not making progress in this field, and I don't have a quick answer to that. I'm not the politician to solve it, but I think it is a huge issue, and it will hold back research and clinical trials. I think Andy's position of we can ignore that and use other variables is a valid one and is actually our only choice of plan of action right now.
If the physician asks us what criteria to use, what do we give him?
Just tell him how you feel about it, really.
Yes, but that's all.
That one's a no-brainer. I mean, you know, why would you ever use outdated 25-year-old criteria? So I think that one I would answer either the international or the Canadian consensus.